Hi, my name is Kelly Bergmann. I'm a pediatric emergency physician at Children's Minnesota, and I'm going to talk today about the diagnostic accuracy of point-of-care ultrasound for intussusception. Some disclosures: Dr. Brandt provides consulting services to GE, and all other authors have no conflicts of interest to disclose. Some common abbreviations you will see: POCUS, which refers to point-of-care ultrasound, and RADIUS, which refers to radiology-performed ultrasound. Intussusception is the most common cause of bowel obstruction among children less than 6 years of age, with approximately 38 cases per 100,000 live births. The gold standard for diagnosis is radiology-performed ultrasound, or RADIUS, which has good sensitivity and specificity. Generally, there are few false negatives or false positives. However, sending patients to radiology leads to delayed ED throughput, higher charges, and unnecessary transfers from adult facilities to children's hospitals for dedicated pediatric radiology services. Point-of-care ultrasound, or POCUS, has shown reasonable sensitivity and specificity for evaluation of intussusception and may alleviate some of these downsides. To date, evidence evaluating POCUS as a tool for the diagnosis of intussusception is limited to single-center studies with small sample sizes. There's been one prospective study assessing the test characteristics of POCUS, which was limited to a sample size of 82 and only 13 positive cases. Retrospective studies are limited by selection bias and are small. More recently, a systematic review was published looking at this population. However, this included only 7 studies utilizing POCUS, 3 of which were actually abstracts, and 3 were retrospective, and 1 was the above-mentioned single prospective study. Given the current body of literature, we sought to further study POCUS for the diagnosis of intussusception in children. Our primary aim was to determine the diagnostic accuracy of POCUS for clinically important intussusception. We specifically sought to study clinically important intussusception, which we defined as provider clinical judgment that enema or surgical reduction would be needed, i.e. ileocolic intussusception, and had a maximal size and transverse diameter greater than 2 centimeters. Also of note, diagnostic accuracy refers to the proportion of correctly identified studies divided by all outcomes. Our secondary aim was to describe the time to diagnosis of clinically important intussusception using POCUS compared to RADIUS. To accomplish our aims, we conducted a multi-center study across 17 sites in North America, Europe, and Australia. This figure shows the geographical representation of study sites. A primary study team was initially formed among 4 investigators and a biostatistician. Collectively, we reviewed literature and vetted the study protocol. Our sample size was determined to be 256 with the following assumptions: RADIUS sensitivity and specificity of 98% after thorough literature review, power of 0.9, a one-tailed alpha of 0.025, and a non-inferiority margin of 4%. A margin of 4% indicates the largest difference between POCUS and RADIUS accuracy that was determined to be clinically acceptable. Site recruitment occurred through the P2 network, which is a group of pediatric emergency physicians with a special interest in POCUS. Site co-investigators had a minimum of 10 intussusception scans in the past with at least 1 positive. All sonographers were also required to watch a video reviewing the study protocol and ultrasound technique. We also reviewed data entry with each site with scheduled conference calls, and we reviewed the data collection tool, which was done using RedCap, and our image archiving, which was done via Sono ClipShare. We included children 3 months to 6 years of age. Children were excluded if they required critical care or if they were transferred and the sonographer was aware of the ultrasound results from a referring facility. In other words, attempts were made to keep the sonographer blinded to anybody that may have had outside facility results and if any patients that may have had RADIUS performed already. Our main outcomes were POCUS and RADIUS results. We further asked sonographers to classify an intussusception as clinically important or ilio-ilial and to rate their confidence in POCUS findings. Time to POCUS or RADIUS was also collected. Time to results for POCUS was defined as POCUS scanning time from start to finish, and time to RADIUS results was defined as time of actual order placement in the electronic medical record to the time of receipt of a read from radiology. We use these values as they practically represent the time at which a treating provider would obtain the information needed to guide clinical care. As of July 16th, we have enrolled a total of 193 children across 14 sites, which represents 75% of our target sample of 256. The table on the left shows basic demographics. Median age is around 20 months, with slightly more males than females. Most patients are of white race and non-Hispanic ethnicity. The table on the right shows presenting signs, history, and disposition. Median duration of symptoms was about 24 hours. Most patients presented with fussiness and parental concern for abdominal pain. Notably, only 22% presented with bloody stool. 6 patients had a recent history of intussusception in the last 14 days. Most were discharged home. This figure shows the number of enrollments by site. As the lead site, we at Children's Minnesota have enrolled 71 children, which represents 35% of the sample. For context, sites with 21 enrollments represent 11% of the sample, and those with 5 enrollments represent 3% of the sample. This flowchart shows detailed POCUS and RADIUS results. Of the 193 children enrolled, 6 were excluded, 4 because the sonographer was aware of results from an outside referring facility, 2 because RADIUS was not performed. In both of those cases, POCUS was positive, but the patients went right to the OR rather than having enema reduction. This resulted in a sample size of 187 children for analysis. POCUS was positive for clinically important intussusception in 44 children, as shown in the bottom left of the screen. Of these, RADIUS identified intussusception as ilio-ilial in 2 cases and was negative in 1 case, and we classified these 3 studies as false positive POCUS studies. POCUS was positive for ilio-ilial intussusception in 12 children. Of these, RADIUS identified 1 as ileocolic, and this was classified as a POCUS false negative. Lastly, POCUS was negative for clinically important intussusception in 131 children. Of these, RADIUS identified ileocolic intussusception in 2 children who were also classified as POCUS false negative. Overall, the diagnostic accuracy of POCUS was high at 97%. The column on the left shows further test characteristics of specificity, sensitivity, and predictive values, which are generally good. Interestingly, accuracy remained relatively the same across varying levels of sonographer confidence in their POCUS findings. There were some variations in sensitivity and positive predictive value for confidence levels less than or equal to 2 or 3. However, the sample sizes in these confidence groups were also smaller and more susceptible to change based on one false positive or false negative result. This figure is a Kaplanmeier curve showing the time to POCUS and RADIUS results. The y-axis represents percentage of patients that would wait for imaging results, and the x-axis represents time in minutes. The median time to POCUS result was 5 minutes compared to 64 minutes for RADIUS. Note that POCUS time represents the POCUS scanning time, and RADIUS time represents the time of actual order placement in the electronic medical record to the time of receipt of a read from radiology. This difference was statistically significant. Our study is limited by a convenient sample of subjects given the impracticality of training all physicians at each site in POCUS bowel sonography. In addition, 35% of subjects have been enrolled from one site, which may have introduced bias and outcomes may have been skewed towards practices at this particular institution. In conclusion, POCUS has a high diagnostic accuracy for intussusception. It can be performed in a timely manner and may be a useful screening tool to guide need for dedicated radiology-performed ultrasound. Thank you for this opportunity. Please feel free to reach me at the above email address if you have comments or concerns or questions. Thank you so much.